Imagine you swallow a single, microscopic pill.
Right, just a tiny little thing.
Yeah, and within about 20 minutes, that tiny cluster of molecules has dissolved in your gut. It's navigated through your bloodstream, ignored your liver entirely, bypassed your heart, and somehow found one specific microscopic receptor in your brain to just shut off a migraine.
It sounds totally impossible when you put it like that.
Right. I mean, how does it know where to go? It's not magic. It's essentially controlled biological chaos.
It is chaos, yeah, but it's a chaos bound by very strict laws. Physics, chemistry, all of that.
Which is exactly why we're here today. Welcome to this deep dive. If you are a medical student staring down your board exams, maybe a young professional on the wards, or just a dedicated self-learner trying to decode the human body, this is for you.
Absolutely. The human body is basically a highly pressurized fluid dynamic machine. If you don't intimately understand the molecular rules governing that machine, tossing a drug into the mix is just guessing.
And we do not want to be guessing. So our roadmap today is the USMLE Step 1 lecture notes for pharmacology. We are skipping the flashcard memorization and diving straight into the actual mechanisms.
Yeah, memorizing names won't help if you don't know the why and the how. We need to understand exactly how these compounds heal, alter, and protect us.
So to do that, we have to start with the fundamental rules of survival, right? The rules for any molecule entering the body.
Exactly. What we call pharmacokinetics. Before drug can bind to a receptor and cure disease, it actually has to survive the journey there.
Right, the whole ADME thing.
Yep, absorption, distribution, metabolism, and eventually excretion.
I was looking at the section on permeation in the notes, and something really stood out to me. For a drug to actually get out of the bloodstream and into a tissue, it has to cross lipid biomembranes.
Right, which are made of fats, essentially.
But it seems like electrical charge is the ultimate gatekeeper here. Like only the non-ionized, the completely uncharged form of a drug can slip through those lipid bilayers.
That is the crucial hurdle, honestly. And this is where the concept of pKi becomes clinically vital.
Break that down for me a bit.
Sure. So most drugs are weak acids or weak bases. This means they don't have a fixed charge. They exist in this equilibrium that constantly shifts depending on the pH of the environment they're floating through.
Oh, I see. So the environment dictates the charge.
Exactly. Take a weak acid drug. In a highly acidic environment, like the stomach, it remains mostly non-hedionized.
Uncharged.
Right. Because it lacks a charge, it's lipid-soluble, and it can easily absorb right through the stomach lining.
But once it gets into the blood, which is slightly alkaline, it shifts.
Precisely. In the slightly alkaline blood, that weak acid gives up a proton. It becomes ionized.
And gains a charge.
Yes. The moment it gains that electrical charge, it becomes water-soluble and lipid-insoluble. It is essentially trapped in the bloodstream until it reaches its target tissue.
Wow. So it literally can't escape the blood.
Right. And the clinical significance of this ionization goes even further when we get to the kidneys. Because ionized, water-soluble forms are much more easily excreted in the urine.
So the body uses electrical charge to basically sweep the trash out.
That's a great way to look at it.
Okay, let's unpack this. So charge dictates how a drug moves and gets eliminated. But once it actually reaches the target tissue, we switch from pharmacokinetics to pharmacodynamics.
Yeah, that's the biochemistry side of things.
The notes talk heavily about affinity, potency, and efficacy. If I'm picturing like a crowded parking lot, is affinity just me having the key to get past the security gate, while efficacy is how well you actually park the car?
Let's refine that analogy just a bit. Affinity is having the right key to the lot, yes. It's how well the drug and receptor recognize each other. It's like the key in enzyme kinetics.
Okay, the key to the gate. Got it.
If you don't have the key, nothing else matters.
Yeah.
But efficacy is the absolute maximum biological effect that drug can trigger once it binds. Think of it like the Vmax.
So it's the horsepower of the engine once you're inside the lot.
Exactly. Yeah. And potency is just the dose required to reach 50% of that maximum effect. But efficacy is the true ceiling.
What if a drug has the key, but no horsepower?
If a drug binds with high affinity but has zero efficacy, it's just a broken down car blocking the parking space.
Broken down car. I love that.
In pharmacology, we call that a competitive antagonist. It takes up the receptor so nothing else can use it, but it does absolutely nothing itself.
That makes perfect sense. So if receptors are the parking spaces, let's look at the biggest parking garage in the body. The autonomic nervous system.
The master switchboard controlling all our unconscious functions.
Right, the constant tug of war between the sympathetic nervous system, the SANS, and the parasympathetic, the PANS.
Fight or flight versus rest and digest. And manipulating this tug-of-war is the basis for a massive portion of systemic medicine.
Let's ground this in a real clinical scenario. The notes use glaucoma as a prime case study for autonomic pharmacology.
It's a fantastic example, yeah.
We are literally hijacking the nervous system to change the physical fluid pressure inside the human eye.
Because open-angle glaucoma is essentially a fascinating plumbing problem. The eye constantly produces a fluid called aqueous humor.
And that fluid needs to drain out, right?
Yes, through a structure called the canal of Schlemm. In glaucoma, that pressure builds up because it's not draining fast enough.
How do we fix it?
We use a dual strategy approach. First, we can administer a cholinergic drug like pilocarpine. Pilocarpine is a cholinomimetic. It mimics the parasympathetic nervous system by activating muscarinic receptors.
And what does activating those specific receptors physically do in the eye?
It causes the ciliary muscle to contract. When that specific muscle contracts, it physically pulls open the trabecular meshwork and widens that canal of Schlemm.
Wow, so you are chemically forcing the drain open to let the fluid out.
Precisely. But you can also just turn off the faucet entirely.
The notes mention using beta blockers for that, right? Adrenergic antagonists.
Yes, drugs like timolol. Timolol blocks the sympathetic nervous system receptors at the ciliary epithelium, which is the exact tissue that secretes the fluid in the first place.
Okay, wait. If we are putting beta blockers into a patient, the sympathetic nervous system uses beta receptors to keep the heart beating.
It does.
So how are we not crashing the patient's heart rate just to lower their eye pressure?
Well, it comes down to two things: receptor subtypes and administration routes. Evolution was smart enough not to use the exact same receptor switch for every single organ.
Oh, right. Beta 1 versus beta 2.
Exactly. The heart primarily relies on beta 1 receptors. The lungs rely heavily on beta 2 receptors. By developing drugs that selectively target just one subtype, we isolate our effects.
And the administration route.
For glaucoma, we administer timolol as a localized eye drop. We bypass systemic absorption almost entirely.
Because if we drop it into the systemic bloodstream, we trigger a cascade, which actually leads perfectly into our next section, cardiovascular and renal pharmacology.
Yeah, the plumbing and the pump. The autonomic nervous system's control over our blood vessels directly dictates the workload of the heart.
The heart is the mechanical pump, and the blood vessels are the resistance pipes it has to push against.
Exactly. If the pipes clamp down, which is hypertension, the pump has to work much harder.
And we treat that hypertension by manipulating the pipes and the fluid volume.
Right. We use thiazide diuretics as a first-line therapy to make the kidneys excrete sodium and water.
Which reduces the total blood volume.
Yep. We also use long-acting calcium channel blockers to stop the smooth muscle in the vessel walls from contracting, which physically widens the pipes. And ACE inhibitors, too.
But what happens when the pump itself starts to fail? The section on congestive heart failure, or CHF, outlines this feedback loop that honestly sounds like a tragic design flaw in human physiology.
It really is. It is the ultimate example of the body's survival mechanisms actually destroying it.
Walk me through it.
When the heart muscle weakens and begins to fail, cardiac output drops. The heart isn't pushing enough blood forward into the systemic circulation.
And the body senses that drop in pressure.
Right. Baroreceptors in the arteries detect the low pressure,
Right.
and the body interprets this as a massive trauma. It literally thinks you are bleeding out in a field somewhere.
Oh, wow. So it panics.
Complete panic.
Right.
It desperately tries to preserve blood pressure. The sympathetic nervous system kicks in, dumping norepinephrine to cause reflex tachycardia.
Meaning it forces the failing heart to beat much faster?
Yes. Simultaneously, the kidneys sense the low blood flow and release an enzyme called renin. This triggers a massive cascade, causing severe edema. It forces the body to retain sodium and water.
Here's where it gets really interesting. The heart is already exhausted and failing to pump the blood it has.
Right.
And the body's natural response is to force it to beat faster, clamp down all the blood vessels, and add more fluid volume to the system.
That is exactly what happens.
That's like trying to put out a grease fire with a bucket of water. You're just giving an exhausted pump more fluid to push against a higher resistance.
That analogy is spot on. This compensation mechanism rapidly overworks and accelerates the destruction of the heart.
So we have to override it.
We have to. Pharmacological intervention in heart failure is fundamentally about overriding homeostasis. We prescribe diuretics to force the kidneys to dump that extra fluid, which reduces the preload.
The volume returning to the heart.
Exactly. And we use ACE inhibitors, or ARBs, to block the renin cascade, which stops the blood vessels from constricting. That reduces the afterload, the resistance the heart has to push against.
What about just forcing the heart to squeeze harder? I know the notes mention inotropes like digoxin.
Digoxin is fascinating. It inhibits the sodium-potassium pump in the heart muscle cells, which ultimately leads to a buildup of calcium inside the cell.
And more calcium means a stronger squeeze.
Right, a much stronger mechanical contraction. It improves the patient's symptoms. They feel better because blood is finally moving.
But there's a catch.
A big one. Making the heart squeeze harder does not improve long-term survival
Wait, really? Why not?
because it doesn't stop the underlying structural damage.
Yeah.
To extend a heart failure patient's life, we have to prevent what we call cardiac remodeling.
Remodeling, like the heart physically changes.
Yeah, when the heart is constantly subjected to high resistance and high sympathetic drive, the muscle tissue literally changes shape. It hypertrophies, it dilates, it scars over.
Oh, that sounds terrible.
It is. Drugs like ACE inhibitors, specific beta blockers, and spironolactone physically interrupt the chemical signals that cause that scarring. They preserve the architecture of the heart.
Wow. Okay, so we've manipulated the plumbing and protected the pump. Let's move from systemic pressure to central control, the central nervous system.
The body's ultimate hard drive.
Right. When a patient goes in for surgery, we use drugs to completely shut down this incredibly complex hard drive.
General anesthesia is truly a masterclass in pharmacokinetics. Let's look at the inhaled anesthetics first.
Okay, the notes decode two crucial metrics here, MAC and the blood gas partition coefficient.
Right. MAC stands for minimal alveolar concentration. This is the concentration of the gas in the lungs required to stop 50% of patients from moving during a surgical incision.
So MAC is a direct measure of a drug's potency.
Exactly. And MAC is tightly tied to lipid solubility.
Right, the notes mention that. Why does being more lipid soluble make a gas more potent?
Because the brain is surrounded by the blood-brain barrier, which is highly lipid-rich. If a gas is highly lipid-soluble, it slips right through that barrier effortlessly.
Ah, so you need a much smaller concentration of it to knock the patient out.
You got it. Therefore, higher lipid solubility means a lower MAC, which equals higher potency.
Okay, so MAC is the strength of the punch, but what about the speed? That's the blood-gas ratio.
Yes. This is a very counterintuitive metric. It dictates how fast the patient goes under and how fast they wake up.
How does it work?
Well, if an anesthetic gas is highly soluble in blood, it acts like a sponge. The gas dissolves completely into the bloodstream, spreading out into all the tissues of the body.
And because it's dissolving so easily.
It takes a very long time for the physical pressure of the gas to build up enough to force its way into the brain.
Wait, let me make sure I have this straight. If it dissolves easily in the blood, it actually takes longer to work.
Exactly. Think of it like trying to fill a bathtub with the drain open. The water just keeps escaping into the pipes.
Okay, I see.
You want a drug with a low blood gas solubility. If it doesn't dissolve well in the blood, the drain is plugged. The partial pressure builds up instantly in the blood, and the only place for the gas to go is directly into the brain.
Fast onset, fast recovery.
What's fascinating here is how MAC is the strength of the punch, while the blood-gas ratio is how fast the fist travels.
That's a perfect analogy. Anesthesiologists balance those two variables in real time during surgery.
What about Humvee anesthetics? When you look at a surgical chart, you see drugs outside of just gases. We use IV drugs for specific, targeted effects. We often use midazolam, a benzodiazepine, purely for amnesia and sedation before we even get to the operating room.
And propofol, I hear that name a lot.
Propofol is used to actually induce and maintain the anesthesia. It's highly lipophilic, hits the GABA receptors to shut down neuronal firing instantly, and has the added benefit of being an antiemetic, meaning it prevents nausea.
I also see ketamine on these clinical lists. I always thought ketamine was a dissociative street drug. Why would a surgeon use that on a patient?
Ketamine works on a completely different pathway. Instead of agonizing GABA to shut the brain down, ketamine acts as an NMDA receptor antagonist.
It blocks excitatory glutamate signals.
Yes, which causes dissociative anesthesia. The patient feels completely detached from their body. But the massive clinical advantage is that, unlike propofol, ketamine doesn't suppress the cardiovascular or respiratory systems.
So they keep breathing on their own.
Exactly, and their blood pressure stays up. Highly useful in trauma.
Speaking of street drugs, the notes touch on how substances of abuse hijack these exact same circuits, like marijuana hitting CB1 and CB2 receptors, or MDMA driving massive serotonin release.
Right, and more importantly, the notes cover how we reverse them.
Let's talk about reversals.
Clinical reversals are vital. If a patient comes into the ER with a severe overdose of benzodiazepine, their central nervous system is massively depressed, they will stop breathing.
So what do we do?
We could administer flumazenil. It's a competitive antagonist. It rushes into the brain, outcompetes the benzodiazepine for that exact same GABA receptor, binds to it, and physically blocks the overdose drug from having any further effect.
And the patient just wakes up.
The patient wakes up.
It's molecular warfare. Up to this point, we've been turning our own cells on and off. But a massive part of pharmacology is chemical warfare against foreign invaders. The antimicrobials, antifungals, antivirals.
The invaders, yes. The entire premise here is selective toxicity. How do we kill them without killing you?
Right. You have to find a biological target that the invading organism relies on, but that the human host lacks.
If you can't find that unique target, your drug will just kill the patient along with the infection.
How exactly do we do that with bacteria?
Bacteria are prokaryotes, right? Their cellular machinery is vastly different from ours. We can target their cell walls with penicillins or cephalosporins because human cells don't even have cell walls.
Oh, that makes it easy. But what about protein synthesis?
That's a great example. A bacteria relies on a specific structure called a ribosome to manufacture its proteins.
But human cells have ribosomes too. How does the drug tell the difference?
Size and shape. Bacterial ribosomes are composed of 50S and 30S subunits.
Okay.
Human ribosomes are 60S and 40S. Drugs like aminoglycosides, macrolides, or tetracyclines are chemically shaped to wedge perfectly into the gears of the bacterial 50S or 30S subunit.
Jamming the factory line.
Exactly. But they physically do not fit into the human 60S or 40S subunits. The bacteria starves of protein and dies, while the human cells keep functioning.
That is incredibly elegant. We can also target nucleic acid with fluoroquinolones or folic acid with sulfonamides, right?
Yes, all unique bacterial pathways.
But the bacteria adapt. The arms race of resistance is a huge theme in these notes.
It is terrifyingly fast evolution. Bacteria don't just sit there. Take penicillin. It works by using a structure called a beta-lactam ring to bind to and destroy the bacterial cell wall.
So the bacteria fights back.
In response, bacteria evolved to produce an enzyme called beta-lactamase.
What does that enzyme actually do to the drug?
Picture the beta-lactam ring as a microscopic chemical square under intense tension. The beta-lactamase enzyme acts like a pair of molecular scissors.
Scissors, okay.
It physically snips one specific bond in that square. The ring pops open, the tension is lost, and the penicillin molecule becomes entirely useless.
So how do we counter that?
We now package penicillins with beta-lactamase inhibitors, decoy molecules that distract the scissors while the actual antibiotic does its job.
A literal microscopic war. What happens when the invader isn't a bacteria but a fungus?
The strategy has to fundamentally shift. Fungi are eukaryotes, just like us. Their cellular structure, organelles, DNA machinery, it's all much closer to a human cell than a bacterial cell is.
So finding that unique target becomes much harder.
Much harder. We usually target their cell membranes. Human cell membranes rely on cholesterol for structural integrity. Fungi rely on a very similar but distinct molecule called ergosterol.
Ah, ergosterol.
Drugs like amphotericin B, a polyene, bind directly to that ergosterol and physically rip holes in the fungal membrane. The cell leaks its contents and dies.
We also have azolase, like fluconazole, that inhibit its synthesis entirely, right?
Correct. And caspofungin targets the cell wall's beta-glucan.
But wait, if amphotericin B is a drug designed to punch holes in eukaryotic cell membranes, doesn't that cause massive friendly fire in the human body?
It does. If we connect this to the bigger picture, amphotericin B is notoriously toxic. It causes severe infusion reactions and is highly toxic to the human kidneys, precisely because ergosterol and human cholesterol are structurally similar enough that the drug occasionally attacks the human cells too.
That's terrifying.
It is. This is why we reserve it strictly for severe, life-threatening systemic fungal infections. We accept the collateral damage because the alternative is death.
And viruses, they hide inside our cells. They don't even have their own machinery.
Which means we have to sabotage their specific life cycle stages. For example, viral absorption with Marviroc, or uncoating with amantadine.
Or nucleic acid synthesis with drugs like aciclovir or zidovudine.
Exactly. Let's look at HIV. It enters a human cell and tricks the cell into producing massive long chains of viral proteins. But these chains are useless until they are snipped into individual pieces by a viral enzyme called a protease.
So we designed protease inhibitors.
Yes, like Indivir. These drugs bind to the viral protease and disable it. The virus still makes the long protein chains, but it can't cut them. It produces immature, non-infectious viral particles.
Sabotage at the assembly line. I love it. Okay, let's pivot to the final phase, The invader is dead or the body has suffered some kind of internal trauma. How do we regulate the cleanup and repair?
We rely on autocoids, blood pharmacology, and the endocrine system. Autocoids are essentially local hormones that act near where they are synthesized, like histamine and serotonin.
We block histamine, the H1 receptor, for allergies, but serotonin is fascinating. Most people just think of it as the happy chemical in the brain, but these notes show it doing massive mechanical work throughout the body.
It is incredibly versatile based on the specific receptor it hits. If a patient has a severe migraine, the blood vessels in their brain are painfully dilated. We can give them an agonist like sumatriptan.
And that hits the 5-HT1D serotonin receptor.
Right. Activating this receptor causes massive vasoconstriction in those cranial blood vessels, stopping the migraine. But if we target a different serotonin receptor, 5-HT3, located in the gut and the brain's vomiting center, we use an antagonist.
Like ondansetron.
Yes, ondansetron blocks the 5-HT3 receptor and completely shuts down severe nausea, which is a total game changer for chemotherapy patients.
From the brain down to the blood. The notes break clinical blood pharmacology down into 3 distinct classes: anticoagulants, antiplatelets, and thrombolytics.
Why are there 3 different ways to deal with a blood clot?
Because a blood clot is a complex structure. When a blood vessel is damaged, platelets rush to the scene and activate, clumping together like sticky bricks.
Okay, sticky bricks.
Then a massive protein cascade activates, eventually producing strands of fibrin. This acts like wet mortar poured over the bricks to lock them into a solid wall.
So antiplatelets prevent the bricks from sticking together, anticoagulants stop the mortar from drying, and thrombolytics take a sledgehammer to the whole wall. I love that analogy, yes. Aspirin is a classic antiplatelet. It irreversibly inhibits COX to prevent platelet activation. Drugs like heparin or warfarin are anticoagulants. They inhibit the fibrin cascade.
So no mortar.
Right. We use antiplatelets and anticoagulants as prophylaxis to prevent a clot.
But if the wall is already built,
That's when you bring out the thrombolytics, like alteplase. They activate plasmin, which acts as that molecular sledgehammer to dissolve the wall. But because you are actively destroying clots, the risk of causing a catastrophic internal hemorrhage is incredibly high. You only use the sledgehammer in a stroke or heart attack emergency.
the constant balancing act of clinical pharmacology. Let's do one last stop: the endocrine system. Hormonal control.
We have a vast array of drugs here: insulin, sulfonylureas, metformin for diabetes, hypothalamic and pituitary drugs like somatropin for growth hormone, or oxytocin for labor.
But the bone pharmacology stood out to me. How do you chemically force the body to build bone in a condition like osteoporosis?
Well, the secret is that you usually don't build it, you just stop the teardown. Bone is living tissue constantly being built up by osteoblasts and broken down by osteoclasts.
And in osteoporosis, the teardown outpaces the buildup.
Exactly. Osteoclasts are activated by a chemical signal called rank ligand. Drugs like alendronate, a bisphosphonate, work by essentially inhibiting that signal. It shuts down the osteoclast's ability to function, tipping the scale back toward preservation.
So what does this all mean? Across the board, from altering the pH of urine to trap a molecule, to jamming a bacterial ribosome, to shattering a blood clot with an enzyme sledgehammer, pharmacology isn't about overriding the body with brute force.
No, not at all.
It's about finding the exact microscopic lever to pull to let the body's own fluid dynamics and biochemistry do the heavy lifting.
It is the ultimate application of applied biochemistry. And since our mission today is to solidify this for the medical learners listening, let's tie this whole journey back to the very first concept we discussed, a rapid-fire clinical review question.
Let's hear it.
If a patient is rushed into the emergency room, having overdosed on a drug that you know is a weak acid, how would you actively change their urinary pH to help them excrete that drug faster? And mechanically, why does it work?
Okay, think about the rules. If it's a weak acid, it likes an acidic environment to stay non-ionized. So we need to change that environment,
Exactly. You would chemically alkalinize their urine.
making it basic.
Right. By raising the pH of the fluid in the kidneys, you force the weak acid drug to give up a proton. The drug instantly becomes ionized.
And because it now carries an electrical charge?
It becomes highly water-soluble. It loses its ability to cross the lipid membrane and reabsorb back into the patient's bloodstream. It gets trapped in the watery urine and is safely flushed out of the body rather than reabsorbed.
You use basic ionization principles to save a life. That is incredible.
It really is. And I'll leave you with this final thought as you hit the books again. Today, we map these intricate pathways based on static chemical shapes. The lock and key of a 5-HT receptor, or the specific shape of a macrolide wedging into a bacterial ribosome. Right.
But as molecular engineering advances, could we one day move beyond static drugs? Could the future of pharmacology be smart molecules that circulate in a harmless dormant state and dynamically alter their own affinity and efficacy only when they sense the exact localized acidic pH of a tumor or the specific inflammatory markers of an active stroke?
A drug that builds its own key only when it finds the right lock. Now that is a brilliant concept to mull over. Thank you for joining us on this deep dive into the USMLE Pharmacology Notes. Keep questioning the chemical world inside of you, keep pulling those biological levers, and we will catch you on the next deep dive.